morning, everyone. I would like to welcome you all today on the occasion of 6th morning regular CME of our GPs Association. And before starting the CME, we will request you to stand up for Doctor's Care, please. Sarve bhavantu sukhina, sarve santu niramya, sarve bhadrani pashyantu, ma kashyitu bhagave, natoham na kame rajyam, na swargam na punabhavam,
Once again, good morning everyone. A very warm welcome to this 6th morning CME. It's my privilege to welcome our learned speaker for today's CME, Dr. Vatsal Gupta, a dynamic and accomplished pulmonologist whose expertise spans pulmonary, critical care and sleep medicine. Dr. Vatsal completed his DM in pulmonary, critical care and sleep medicine from AIIMS, Patna, MD in Pulmonary Medicine from VP Chest Institute, Delhi, and also holds a DNB in Respiratory Medicine. He is presently serving as a consultant pulmonary medicine at City Super Specialty Hospital, Gorakhpur, and has contributed significantly to academics with 14 publications in various national and international journals. Today he will enlighten us on a topic of immense clinical relevance, obstructive sleep apnea, a common yet overlooked diagnosis in primary care. Let's welcome Dr. Vatsal Gupta with a warm round of applause to share his insights and guide us through the topic.
So, very warm good morning to all. So, the topic which I will be speaking today is obstructive sleep apnea. So, before beginning this topic, so what is the spectrum of sleep disorders? According to ICSD, that is International Classification of Sleep Disorders, 3rd revision. So the sleep disorders are commonly divided into 6 major categories. First one is insomnia disorder, which is difficulty in falling asleep or staying asleep. Then there are sleep related breathing disorders, of which one of the subtypes is obstructive sleep apnea, which we will be dealing today. Next is the central disorders of hypersomnolence, in which there is intrinsic abnormalities of the central nervous system in the control of sleep wave. It includes disorders like narcolepsy and idiopathic hypersomnolence. Then there is circadian rhythm sleep-wake disorders, in which a biological clock of the body gets disturbed, such as in shift lag workers or a person doing night duties continuously. The sleep-wake cycle gets disoriented. Next is the parasomnias, which is characterized by abnormal behavior during sleep, commonly found both in children and adults, such as sleepwalking, sleep talking, sleep eating, night terrors. This is the spectrum of parasomnias. After that, the next category is sleep related movement disorders, in which there is abnormal movements that occur during sleep, which can include disorders such as restless leg syndrome, periodic limb movement disorders, etc. So today we will be discussing mainly about sleep related breathing disorders. These breathing disorders has its own spectrum, of which the most common which will be deal today is obstructive sleep apnea, that is OSA, both in adults and pediatric population. Then there is central sleep apnea. Then there is sleep related hypoventilation syndrome, in which there is difficulty in the exchange of oxygen, of which the most important is obesity hypoventilation syndrome. And last is the sleep-related hypoxemia disorder, where there is a problem in the exchange of gas at the alveoli level. So today what we will be dealing with is OSA. What is basically OSA? It is the most common sleep disordered breathing. It is a dangerous disorder. It can be easily recognized by physicians in the community, and it is a treatable condition. So what happens in there? It is characterized by recurrent episodes of partial or complete upper airway obstruction. But what is written here is it is characterized by repeated episodes of hypoxia, sleep fragmentation and sympathetic overactivity. Hypoxia means that is decrease in the oxygen saturation. Sleep fragmentation means that your sleep gets broken in between during the night, and sympathetic overactivity, which eventually leads to a lot of complications. Next, we'll see the epidemiology. So, disorder is more common in men compared to women. When we compare women, it is amongst women it is more common in post-menopausal women compared to pre-menopausal because of the protective effects of the hormones. The worldwide prevalence of this is about 1 billion. People aged 30 to 65 years are affected by OSA, of which nearly half, that is nearly 425 million, are suffering from moderate to severe OSA. What is moderate to severe OSA, which we will see later. So these are the countries which have most maximum burden of obstructive sleep apnea, of which India is one of the countries. So this was a meta-analysis according to, just to find out what is the prevalence of this disorder in the Indian population. So the overall prevalence is around 11%, in males it is 13%, females it is 5%, and when we look at the more important category, that is moderate to severe OSA, it is around 5%. Taking this into numbers, approximately 104 million Indians of working age suffer from OSA, of which nearly half, that is 47 million, have moderate to severe OSA. Now, after the epidemiology, we will see what are the risk factors for this condition. So, the most important risk factor for this condition is obesity and high BMI. BMI of more than 30 predisposes you to the risk of OSA, and this is a linear correlation. That is, as the severity of, as the BMI increases, the severity of OSA increases. This is not clearly visible, but the second point is also very important, that is the neck circumference. Your neck circumference more than 17 inches in male and 15 inches in female. In centimeters it is 43 and 38 centimeter in male and female respectively. So your high neck girth is also an important risk factor for OSA, apart from obesity. Next is male gender, which we already saw, and age more than 40 years. Apart from that, the other risk factors which form a part is the positive family history. If there is first generation is suffering from the OSA, then the following generation also have an increased risk. Smoking and alcohol use, what does this do? It contributes to airway inflammation and the relaxation of muscles, which also predispose to OSA, smoking and alcohol use. Then there are certain medications, certain health conditions such as diabetes, hypertension, heart failure. All these conditions intrinsically predispose you to sleep apnea. Per se, sleep apnea increases the chance of these conditions. Apart from that, obstruction in the nasal cavity such as nasal polyposis, deviated nasal septum, chronic sinusitis, all this predispose you to OSA. Then use of sedatives or tranquilizers. These relax your neck muscles and throat muscles, so it predisposes you to the risk of sleep apnea per se. So these were the significant risk factors which we have to remember is obesity, high BMI, high neck circumference, male gender and age more than 40 years. Now what is the pathogenesis of OSA? There are two main factors. There are anatomical factors and neuromuscular factors. In anatomical factors, upper airway narrowing, which can occur due to any cause. What happens in obesity? In obesity, there is excess fat deposition around your pharynx, tongue, soft palate, which narrows your opening of the upper airway. Then there is enlargement of the soft tissue such as tonsils, soft palate, adenoids. All this narrows your upper airway cavity. Then craniofacial structures. Certain diseases or in certain individuals there is retrognathia, that is your mandible is slightly backwards. That is also a risk factor for OSA. That's body position. Lying down in a supine position causes shift of fluid from your legs to the upper part of the body, that is neck. This also, lying down in a supine position also predisposes you to risk of OSA. Then there are neuromuscular factors. What are neuromuscular factors? In neuromuscular factors, what happens is your upper airway reflexes during sleep. The muscle tone during sleep reduces. When we are awake, our muscle tone is good and it prevents us from the collapse of upper airways. But during sleep and predominantly in patient with OSA, the muscle tone is reduced. The reflexes which prevent upper airway from collapse, they are also hampered. So when hypoxemia occurs, there is an arousal response. So both these factors together, what they do, they cause oxygen levels to drop. When oxygen level drops, you wake up from sleep, that is arousal. And when you wake up, your muscle tone comes back to normal, this function resumes back, and you start breathing again. But this cycle keeps on repeating again and again and again, which causes obstruction, desaturation and arousal, which eventually leads to a fragmented sleep. That is, your sleep is broken multiple times during the night, and when you wake up in the morning, you have an unrefreshing sleep. You complain of complain of sleepiness during the day and early morning headaches. So this is what I told. There is a decline in oxygen saturation, there is an arousal, there are pressure changes. All these mechanisms lead to sympathetic activation, endothelial dysfunction, then there is hypercoagulability, there is inflammation, oxidative stress, metabolic dysregulation. This intermediate mechanisms predispose you to multiple comorbid conditions, multiple systemic problems, most important of which is hypertension. Hypertension, that is resistant hypertension, where you at times you are giving beta blockers, you are giving ACE inhibitors, you are giving diuretics, you are giving calcium channel blockers, but still the patient's BP is higher side. So when we try to look into the intricate cause of that, this remains untreated in many cases. Apart from that, heart failure, which predisposes you to both obstructive sleep apnea, central sleep apnea. Then there is risk of stroke. OSA per se increases the risk of stroke, and all these conditions, if left untreated, they also predispose you to the risk of stroke. Then there is myocardial ischemia or infarction, sudden death. We hear many young individuals, 45, 50 years, they are on medical cardiac medications. We hear that they slept and next morning they did not wake up, despite being treated for all these conditions. Because in many cases the untreated entity remains there as an obstructive sleep apnea. Then it predisposes you to the risk of atrial fibrillation as well. So the point which we should keep in mind, that screening of OSA in patients with resistant hypertension is reasonable. You should always screen patients who are on 2 to 3 antihypertensive medication, screen them for OSA. Next, the likelihood of atrial fibrillation is increased 4 to 5 times in patients with sleep disordered breathing. Next, sleep disordered breathing is encountered in patients with heart failure, which may present at OSA, central sleep apnea or kind strokes breathing. All these factors together increase the risk of stroke. Per se, OSA also increases the risk of stroke independent of these factors. Now, after going through the pathogenesis, we look at the clinical symptoms. Then, if a patient presents to you in OPD, if he is having risk factors, what questions do you ask him? So, the symptoms can be divided into the nighttime symptoms and daytime symptoms. During night, what happens? The most common symptom is loud, persistent snoring. Just minimal snoring is not a snoring which affects the bed partner or the members of the house is important. So, loud, persistent snoring is the most common, one of the most common symptoms. Then witnessed pauses during breath, or choking or gasping episodes in air. If someone, your bed partner, has encountered this, your pauses, snoring in sleep, that is one of the most specific clinical findings, clinical history, which predisposes the person to OSA. So, if these things are present, it is near certain that the patient has OSA. Then fragmented sleep, what we saw, which will lead to restlessness. A person will wake up multiple times at night to go to the washroom. Then during the daytime, what will happen? If his sleep is not good during the night, so he will complain of early morning headache. He will sleep during the day. Whatever activities he does, he will have poor concentration, he will be irritable. And during daily activities, during maybe his work or reading newspaper or eating food, he can fall asleep during day-to-day activities. So once we have diagnosed, once we have looked at the clinical history and examination, we try to diagnose this entity. So apart from history, what else you can do in OPD setting? We can look at the structure of the upper airway, which is according to the modified Malampatti classification. This is commonly used by anesthetist before the patient, taking the patient for intubation or before any elective procedure. So as the severity of Malampatti classification increases, the risk of obstructive sleep apnea increases. So In Malampatti 1, we can see everything. We can see the uvula, we can see the soft palate, we can see the lateral tonsillar pillar. So this is a good airway. It has less chances of OSA, and your anesthesia process will also be easier with this thing. Now when we move from Malampatti 1 to 2, the lateral tonsillar pillars are not visible. In 3, we can only see a bit of uvula. And in 4, we cannot even see the soft palate, we can only see the hard palate. So this is something which we can just open the mouth and see what is the Malampatti score and proceed further for the diagnosis of obstructive sleep apnea. So then there are screening questionnaires which can be used in outpatient setting for the diagnosis of OSA. So the most common which we use in our day-to-day practice is stop bank scores. Stop banks is the mnemonic for all this 8 entity which we use. S stands for snoring. So what do you specifically ask in snoring? Do you snore loudly? What does loud means? Loud means to be enough to be heard through the closed doors, or your bed partner elbows you for snoring. Your bed partner is constantly troubling you, you're constantly making you wake up and saying that you are snoring too much, then this is a troubling sign. Do you feel tired during the day, fatigued or sleepy during the daytime hours, such as even you are driving a car, you fall asleep? So this is a very hazardous thing. If you fall asleep while driving, you predispose yourself to a risk of major road traffic accident. Then O stands for observed apneas. Has someone observed you to stop breathing or choking, gasping episodes during sleep? If this is positive, I told that this is a very, very specific finding which predisposes to obstructive sleep apnea. Then pressure. Pressure means blood pressure. If you are on antihypertensive medications or your BP is persistently elevated. Next is BMI. Your BMI is more than 35. Even above 30, it predisposes you. But in this, we take it, on this score, we take it more than 35. Age more than 50 years. Neck is for neck circumference, more than 17 inches in male and 16 inches in female. And male gender. So out of this, you give a score of 1 if it is positive. According to this, if your score is 0 to 2, you are at low risk of OSA. 3 to 4 is intermediate risk of OSA, and 5 or above is the high risk of obstructive sleep apnea. So the next questionnaire which we use in our OPD is the ESS, that is Epworth Sleepiness Score. What it does, it sees your ability to, your chances to fall asleep during certain conditions of the day. It is given a score of 0, 1, 2, 3. That is how much you have no chance of dozing, slight chance of dozing, moderate chance of dozing or high chance of dozing. There are certain questionnaires such as sitting and reading, watching television, sitting in public inactive, riding a car. There are certain questions which we give to the patient and he has to mark it. So if your score is 0 to 10, it is normal. 11 to 14 is mild sleepiness, 15 to 17 is moderate sleepiness, 18 or above is severe sleepiness. Now, after we have done the screening, we have to confirm the diagnosis. So, polysomnography is the standard for diagnostic confirmation. This is type 1, type 2, type 3 and type 4. So, the gold standard for sleep diagnosis is a type 1 polysomnography. What we have to know is what are the parameters which we look in a polysomnography recording. So, it can be divided into 3 parts. There are neurological, that is sleep related parameters. There are respiratory parameters and there are cardiovascular parameters. So the sleep related parameters, that is neurological parameters, are EEG, that is electroencephalogram, EOG, electrooculogram, EMG, electromyogram. So these look into your various aspects of sleep. How do you sleep? Whether you are progressing from non-REM sleep, REM sleep, you are going into different stages of non-REM sleep, that is 1, 2, 3. EEG is for that. EOG is ocular movements. So the sleep is divided into 2 parts basically, non-REM and REM. In REM movement, it is like an active sleep. Your brain is constantly active. There will be things, your oculography will be active. And then is EMG, that is myography. In such as in REM sleep, there is atonia of the muscles. These are the parameters which we look for in a type 1. Then there are ECG, cardiovascular. Then the respiratory parameters, what is most commonly used to make a diagnosis of OSA. It is the airflow. Airflow is your nasal airflow, oral airflow. 2 devices which are used is nasal pressure transducer or oronasal thermistor. Then there is effort. There are two bands on your chest and abdomen which we place at night to look at whether your respiratory efforts are there or not. Then there is pulse oximetry, oxygen saturation, which we monitor throughout the night. In type 1, there is basically a technician is there and it is done in a lab setting. You cannot do a type 1 polysomnography at home. There has to be a sleep lab and there has to be an attendant technician. Then there is type 2. Type 2 is same as type 1. We put all these parameters, but it is done without the presence of a attendant. Matlab there is no one who will settle your leads or something, and people are doing this at home also, but it is usually not recommended. Either you go for type 1 or you go for type 3. Type 3 is basically where you do not look at the neurological parameters, that is EEG, EOG, EMG, but you look at the ECG, airflow, effort and oximetry. This can be attended or unattended, and this can be done in the hospital setting or at the home setting. When it is done in the home setting, it is called as HSAT, that is home sleep apnea testing. So in patients with moderate to severe OSA, such as in OPD you encounter a patient who is nearly 100 kgs, he has a short neck, he is 55 years male. So you can straight away go for this test, because at times both these tests have similar concordance. But if a patient has resistant hypertension, heart failure, it is better to go for type 1, because during sleep study you will encounter many other parameters apart from sleep apnea which you need to encounter during sleep. And this type 4 is the kind of just there are two sensors in this, where is oximetry sensor and there are respiratory efforts, which is done by a device called as actigraphy. You sleep it with night for 2 to 3 days, then it will generate a report, and you can just it is basically just a screening test. You need this or this for making a diagnosis of obstructive sleep apnea. So in last, what we say is in-lab ESG is the gold standard test for diagnosis of sleep apnea. Type 3, what I told, it is unattended respiratory polygraphy. It is a feasible option with an equivalent diagnosis to in-lab ESG and good concordance in patients with high pretest probability of moderate to severe OSA. It underestimates the AHI. AHI is the apnea-hypopnea index. We'll see about this later. So this is how a sleep recording looks like. So this might look complicated, but these are the EEG parameters. Then this is the chin, that is electromyography. Then in sleep apnea, what we see is airflow pressure. This is not clearly visible because of the color. But what we see is airflow pressure transducer, nasal pressure transducer. Then chest and abdomen, there are leads. So what we will see basically is, it's not clearly visible. In chest and abdomen, there is cessation of airflow. That is, there is no airflow going through your upper airways. It will appear as a flat line. It is normally like this, and if it appears as a flat line for 10 seconds, there is obstructive apnea. What we see in chest and abdomen, whether there are efforts or not. If this is a flat line and efforts are there, so it is an obstructive apnea. If it is a flat line and there are no efforts also, then this is a central sleep apnea. That is, we are not getting even the your neurological system is not working well to give even the stimulus to the chest and abdomen to breathe. So that makes a diagnosis of central sleep apnea. Then we continuously monitor the saturation throughout the night. We continuously monitor the ECG. We monitor the pulse. The next is the right and left leg. Electromyography is done to look at the tone of the muscles, which helps in differentiating from REM and non-REM sleep. So what are the parameters which we actually see in a polysomnography report? So what we have to see is a sleep latency, that is in how much time you are falling asleep. If it is less than normally is less than 20 minutes, if it is more than 30 minutes, it is considered abnormal, and it can also help you make a diagnosis of insomnia. Although insomnia is not classically diagnosed with polysomnography, but it can be done. Sleep efficiency, that is, it should be 85%. Matlab the time during sleep, we should be time on bed in which you should be asleep should be more than 85% of the overall time that you have spent. Then there are sleep stages, which we saw that EEG, EOG and EMG. They helps in dividing the sleep into non-REM sleep, REM sleep and REM latency. Non-REM sleep is divided into N1, N2 and N3. N3 is the deep sleep. Deep sleep is essential for physical restoration. Matlab, if you go into N3 sleep, you will wake up in a better state tomorrow morning. REM sleep is the rapid eye movement, which is usually seen in the early hours of the morning. This helps in memory consolidation. And REM latency, how much time it takes you to fall into REM. When you are awake, then you go into a slightly drowsy state, then you progress into N1, N2 and N3, and then you can progress into REM sleep. The time to go into REM sleep is approximately 90 to 120 minutes. Then there are respiratory events. What we measure is apnea and hypopnea. What is apnea? Apnea is cessation of breathing for 10 seconds, where there is more than 90% reduction in the airflow. Hypopnea is reduction in airflow by more than 30%, and it should be associated with an arousal. That is, because of that reduced airflow, you should wake up or desaturate, or there should be more than 3% desaturation. So we measure these indices in per hour of sleep. That is what we have to remember, per hour of sleep. A normal AHI is usually less than 5. 5 to 14 is mild, 15 to 29 is moderate, and more than 30 is severe obstructive sleep apnea. Then we continuously monitor the saturation throughout the night. If your saturation drops below 90, it indicates that there are multiple risks. You are at risk of multiple cardiovascular complications in future. Then there is periodic limb movement disorders, which we can also find out with this polysomnography report. Now, after we have made the diagnosis, we have to provide the treatment options to the patient. So what are the treatment options? So we begin always with a behavioral intervention. What is there in behavioral intervention? We will see. This is non-invasive medical treatment, of which PAP therapy, that is positive airway pressure therapy, forms the most important part. Then there is surgical treatment, and then there is targeted pharmacotherapy. So what we can do as a part of behavioral intervention? The most important is weight loss. So how do we motivate the patient for weight loss in obstructive sleep apnea? The text says that 1% reduction in weight is equal to 3% reduction in AHI. So if an individual with 100 kgs presents to you, and we tell him, do you try to reduce your weight by 10% in next 3 to 4 months? So from 100 kg, if he reduces to maybe 90 kg, that is 10% of his weight loss. So his AHI will reduce by 30%. So just say that his AHI is nearly 20. So if it reduces by 30%, his AHI, next time we do a sleep study after 3 to 6 months, it comes down to less than 15. So he goes into the category of mild OSA. So this is the motivation which we can give to the patients of sleep apnea, that if you reduce your weight loss, your 30% AHI will go down. But the same patient, if his AHI comes out to be nearly 70, you try to reduce his weight by 30%, 10%, his AHI from 70 comes down only to you say 50. Then also he lies in the category of severe OSA. So per se weight loss cannot cure a problem of obstructive sleep apnea. Apart from that, you have to ask the patient to do exercise. Positional therapy means that you ask the patient to lie down in left lateral or right lateral position, so that your fluid return from the lower part to the upper part is less. So we can give thoracic bands such as a ball placed at the back, so that it makes the patient sleep in the lateral position. Then you have to avoid smoking, alcohol and caffeine intake at the night. In non-invasive medical management, there is PAP therapy, which is CPAP, APAP, BiPAP. All these has their own indication. CPAP is continuous positive airway pressure, APAP is auto-titrating positive airway pressure, and BiPAP is bi-level positive airway pressure. All this has its own indications. The next is mandibular advancement devices. What it does is, when your jaw is a bit back, by surgical correction you try to move the jaw forward, so that it makes space for your upper airways, so that your breath can go in easily. This is also one of the management. So an interdisciplinary discussion with a good dentist who is doing these things is essential at times in management of sleep apnea. Then there is surgical interventions. So in pediatric OSA, the most important treatment for OSA is treatment of your tonsils and adenoids. So tonsillectomy and adenoidectomy is the most important surgical treatment. Apart from that, in adults, what we can do is nasal surgery such as DNS surgery or polypectomy. Then there is maxillomandibular advancement, uvulopalatopharyngoplasty. If there is patient is super obese, morbidly obese, you can go for bariatric surgery. And if your stimulus to the upper airway is low, you can go for hypoglossal nerve stimulation. And the last resort is tracheostomy. If your upper airways are closed and nothing works, last is you make an opening here, so that this entire pathophysiology which lies here, that is abolished. So last step is tracheostomy. Then there is certain pharmacotherapy. For pharmacotherapy, you need to dig in deep. You need to take a detailed history. You have to do an in-lab polysomnographic titration to understand what is the exact pathology. So at times there we might have to give sedatives to the patient when he has a low arousal threshold. That is, he's waking up multiple times during the night. So we have to give him a sedative. Then there is high loop gain. We have to at times give oxygen therapy, acetazolamide therapy. Then we have to give nasal decongestant, or appropriate management of the underlying condition is the pharmacotherapy. Then there are drugs for weight loss such as orlistat and semaglutide. Not always the first line, but as an additional add-on therapy if you have the experience of using it. So PAP therapy in OSA, it must be used in a patient with excessive sleepiness, impaired sleep-related quality of life, comorbid condition. Always initiate the patient with CPAP or auto-titrating PAP over BiPAP in the routine treatment of OSA. If you have made a diagnosis of OSA HI15, better not to start with a BiPAP. A BiPAP machine is twice as costly as a CPAP machine. So just give him a CPAP machine, ask him to use it and come back with you with the report. Or if he is not ready for titration, give him an auto-titrating PAP. Ideally, for auto-titrating PAP, you have to fix the pressures. The fixed pressure you have to give on that pressure overnight. Then you have to educate the patient. Without educating the patient, you give him the CPAP, he'll throw away the machine in 2 days, he's saying, I'm getting more problem after using this. So educational therapy, you have to basically do what are the problems. You have to ask him the problems, what he is encountering. You have to ask him to review after 3 days. Try to solve the problem if there is a mask problem, if there is a leak problem, if there is a nasal obstruction problem, if there is a dryness of throat problem. There are nearly 8 to 10 complications which are associated with PAP therapy. So you have to encounter each one of them for making your patient compliant. And it works wonders. PAP therapy works wonders in patients with OSA. If a patient starts using, and if you give him for 1 month, at times after 1 month, he'll come back to you and he'll say to you that, doctor, you have changed my life, and overall quality of life has become much better. So that's all from my side. So this, what does this photo just say? So if you are snoring and your wife is getting disturbed by your sleep, so it's high time for you to get tested and get treated, so that you can have a happy life and a happy wife. Thank you.
Thank you, Dr. Vatsal, for an insightful and comprehensive, very excellent presentation. Thank you so much. A big round of applause for Dr. Vatsal. So next we'll move towards the quiz before we forget the session. So after the quiz session, we'll go for the Q&A. What is the primary pathophysiological event in obstructive sleep apnea? Option A, central nervous system respiratory drive failure. Option B, alveolar hypoventilation due to chest wall deformity. Option C, impaired gas exchange. Option D, recurrent collapse of the upper airway during sleep. Option D, recurrent collapse of the upper airway during sleep. That's the right answer. A big round of applause.
So we saw in the slides that the problem is at the upper airway level. Your oropharynx, that gets obstructed most commonly in OSA. Apart from that, this central nervous system respiratory tract failure is commonly seen in central sleep apnea. Alveolar hypoventilation due to chest wall deformity. When there is neuromuscular disorder, there is problem in gas exchange, and there is alveolar impaired gas exchange commonly seen in hypoxemia related disorder. And in OSA, what we encounter is collapse of the upper airway during sleep.
Great. Bad luck, Dr. Sanjeev. First उठाया था आपने. सर की नजर नहीं गई. So second question will be from this side. Patients with untreated OSA are at an increased risk of developing autoimmune diseases, spontaneous pneumo, motor vehicle accident, or is it acute pain? Just raise your hand. Sir will select. Dr. Pradeep.
Motor vehicle accidents.
Yes, that's the right answer. Big round of applause. Motor vehicle accidents.
So, what does OSA basically do to you? When you have a fragmented sleep or disturbing sleep at the night, you have symptoms of daytime sleepiness, your concentration goes down, your cognitive functions goes down. You can even sleep while you are driving your car. So that is a major health hazard for. So if you are an OSA patient and you are not using PAP therapy, better not drive a car. Always use a driver for yourself and prevent going on long drives.
So the third question will be from my left side. Apnea is defined as the cessation of airflow for at least how long? Just raise your hand.
Those who have already attempted have. 10 seconds.
10 seconds is the right answer. A big round of applause for sir.
एक बार जीत चुके हैं वो हाथ में उठाएं.
What we measure in obstructive sleep apnea is AHI, that is apnea hypopnea index. So we have to know the definition of apnea. Apnea is cessation of airflow for at least 10 seconds with greater than 90% reduction in the airflow. What is hypopnea? Hypopnea also has a duration of 10 seconds, but there is reduction of airflow of more than 30%. And it should be associated with an arousal, which means that you have to awaken from your sleep for a short duration, or your saturation should fall down for more than equal to 3%. So this is the definition of hypopnea. This parameter we measure over the entire night, and the index, that is AHI index, is calculated over a period of 1 hour, and based on this we divide the sleep apnea into mild, moderate, severe, that's it, mild, moderate.
So the next question is, a patient with an HI of 25 events per hour would be classified as having, from this side, is it primary snoring, mild OSA, moderate, or is it severe OSA? Just raise your hand. Severe OSA is not the right answer. Any other?
More than 30 is severe. Moderate.
Dr. Ashok. Mild is not the right answer. So you can try your luck. Anyone can try. Dr. Mihir. Moderate is the right answer. Great. Good round. Good. बहुत अच्छा.
In OSA, we divide AHI less than 5 is considered as normal. So 5 to 14 we take it as mild, 15 to 29 is moderate, and more than equal to 30 is severe OSA. That is it.
I think
The last.
This is
the last. Okay. So from this side, yeah, both sides. Anyone can answer. 55-year-old male patient who is candidate for bariatric surgery. He is 175 centimeter, 120 kg, and has an arterial hypertension for which he takes Ramipel. His wife tells you the patient snores during the night. His blood pressure is 125/75, and pulse oximetry is 89% on room air. What is the most appropriate management of this patient? Proceed to surgery without further testing. Option B, perform an arterial blood gas analysis. Option C, recommend positive airway pressure treatment at night and proceed to surgery. Or is it option D, postpone surgery and proceed with sleep study? Just raise your hand. Just raise your hand. Option C, recommend positive airway pressure treatment at night and proceed to surgery. That's not the right answer. That's not the right answer.
Just not right. Either D. Dr. Chaturvedi ka.
Dr. Chaturvedi, sir? Postpone surgery and proceed with the sleep study. That's the right answer. Big round of applause for sir.
So, bariatric surgery is not an emergency surgery. It is an elective surgery, and at times before surgery, you have to, since the patient is having comorbidities, you have to get the patient tested properly and start him on PAP therapy. Maybe his PAP therapy responds very well, And after that, if it is not responding, we can go ahead with the bariatric surgery. So since it is an elective surgery, you can always postpone the surgery and proceed with the sleep study, because these patients, when we take on invasive mechanical ventilation, what the anesthetist will say that after the procedure, his saturation is not met. You will have to keep him on ventilator. So that is not a solution. After your surgery, the patient should come out. So if you have to keep a patient on positive pressure therapy after the surgery, so once you have diagnosed him with OSL, you can and started him on PAP therapy, you can priorly tell the patient that this is going to be your course, that after the surgery you will require a PAP therapy for some time. So it is always better to get tested and then proceed with the surgery.
Our opinion should be different. Bariatric surgery is needed for his obesity problem. And OSL is something different, other co-existed situation. So approach for OSL will be different, approach for obesity and metabolism will be different. These two should not be combined together. That's why the question for bariatric surgery approach, it should not be.
Just a bit of
Just to make some confusion. पहले जान बचानी है, मोटापा तो बाद में आपके
इसीलिए बात
तो पहले सांस को कंट्रोल करो, सांस आएगी तब ना सर्जरी करेंगे।
मेरा पर्पस ये था कि बैरियाट्रिक सर्जरी डिफरेंट
टॉपिक।
अगर आपको करना है तो लोकल सर्जरी को लेकर के क्वेश्चन बनाते तो डेट विल बी बेटर आंसर कि इसके लिए, जो कि लोकल सर्जरी ओएसएल में कभी-कभी की जाती है। सक्सेसफुल हो या ना हो, दैट इज डिफरेंट।
Exactly.
So now the session is open for Q&A. Any questions from the audience?
एक चीज हम और जानना चाहेंगे, सीपैप जैसे लगाते हैं, मतलब जैसे कह दिया लगा हुआ है, सीपैप की प्रैक्टिकल प्रॉब्लम क्या होती है, एक चीज। दूसरा नेजल पैप और वो जो चीज आती है या नेजल क्लिप वगैरह आती है, वो सब क्या मतलब कुछ इफेक्ट है कि बस यूं ही है?
तो दो क्वेश्चन है। तो पहले मैं व्हाट आर द कॉम्प्लिकेशंस ऑफ यूजिंग अ सीपैप?
कॉम्प्लिकेशन नहीं, प्रैक्टिकल प्रॉब्लम।
सो प्रैक्टिकल प्रॉब्लम सबसे कॉमन क्या होती है कि ड्राइनेस होता है। तो आपको पूरा मुंह ड्राई होगा, आपका नोज ड्राई होगा, तो उसके लिए क्या ट्रीटमेंट है? यू कैन यूज अ ह्यूमिडिफाइड। आपके साथ जो सीपैप मशीन होती है, जो न्यू मशीन आ रही है, उसमें एक ह्यूमिडिफायर लग गया है, तो वो प्रॉब्लम उससे सॉल्व हो जाती है। दूसरा योर नेजल ड्राइनेस। सो व्हाट यू कैन डू फॉर नेजल ड्राइनेस, यूज normal saline nasal droplets or a soft steroid such as mometazone for your nasal problem. Third problem is your leak. लीक के लिए क्या प्रॉब्लम है? आपको मास्क प्रॉपर साइज का होना चाहिए। सो जो ओरोफेशियल मास्क आते हैं वो स्मॉल, मीडियम और लार्ज। सो सी द फेस ऑफ द पेशेंट एंड आस्क हिम टू यूज फॉर अ फ्यू डेज, एंड व्हेन ही इज सैटिस्फाइड विद दैट थिंग, देन ओनली आस्क हिम टू परचेज द मास्क। आपके पास हाथ में क्या आ सकता है? The company which is providing CPAP, that will give you a compliance report, that even after using it for 1 day, you will get a report in hand regarding how many hours he used that device at night, how much was the leak, whether there was significant leak or not, how much was his AHI reduced, मतलब कि उसका AHI हमने मान लीजिए 30 की AHI पे दिया, पैप लगाने के बाद कम से कम 5 से नीचे आया कि नहीं आया। तो ये सारी आपके पास एक नेक्स्ट डे स्लीप स्टडी, एक टाइट्रेशन रिपोर्ट आती है, उसको आप देख के जो भी प्रॉब्लम आप एनकाउंटर करते हैं, आप उसको पेशेंट को सजेस्ट
कुछ प्रेशर से जाता है क्या?
हाँ सर, एक पॉजिटिव प्रेशर देता है जो कि आपके अपर एयरवे को ओपन रखता है।
पीएपी मतलब पॉजिटिव एयर प्रेशर।
और नेक्स्ट क्वेश्चन जो होता है, व्हाट आर द इंटरफेसेस दैट वी यूज फॉर पॉजिटिव एयरवे प्रेशर? सो पहले होता है नेजल क्लिप्स, मतलब नेजल पिलोज, जिसमें हम एक जैसे नेजल प्रॉन्ग होता है, उसी का मोटा नेजल प्रॉन्ग को हम नेजल पिलोज कहते हैं। तो अगर किसी का प्रेशर बहुत कम आया, मान लीजिए किसी का टाइट्रेशन स्टडी पे रिपोर्ट आई कि सिर्फ उसको पैप प्रेशर 5 की जरूरत है, तो 5 to 6 प्रेशर कैन बी इजीली डिलीवर्ड विद अ नेजल कैनुला। अब उससे ऊपर का प्रेशर जाता है कि 6, 7, 8, 9, 10 में भी 11, 12 तक, यू कैन यूज अ नेजल मास्क। आप सिर्फ आप आता है किसी का प्रेशर जो हम टाइट्रेट करने के बाद निकालते हैं 15, 16, 17, 18 देने वाला मास्क। फिर इसमें कुछ नया टेक्निक आ गया है कि ओरल मास्क विद नेजल पिलो, मतलब ओरोनेसल मास्क यूज करते हैं। तो दिस वाज अबाउट द व्हाट आर द इंटरफेसेस एंड व्हाट आर द कॉम्प्लिकेशंस ऑफ यूजिंग, या व्हाट आर द ट्रबल शूटिंग फॉर यूजिंग पैप।
इसमें पोस्चर कैसा होना चाहिए जो है?
कोई भी पोस्चर में सो सकते हैं, सुपाइन में भी सो सकते हैं, ऐसा कुछ नहीं। इफ यू आर नॉट यूजिंग सीपैप, देन इट इज बेटर फॉर यू टू यूज लेफ्ट लैटरल और राइट लैटरल, बट इफ यू आर यूजिंग पैप, यू कैन स्लीप इन एनी पोजीशन उसमें, बिकॉज योर एयरवे इज ओपन. आप नॉर्मल भी जब पेशेंट ठीक है वो तो किसी पोजीशन में भी सो सकता है. सो पैप थेरेपी मेक्स योर एयरवे नॉर्मल, सो यू कैन लाई डाउन इन एनी पोजीशन आफ्टर यूजिंग पैप. So, when we go deep into the pathogenesis of obstructive sleep apnea, when we go deep into the pathogenesis of obstructive sleep apnea, अब इसमें कई बार क्या होता है कि the problem lies in patient is awaking multiple times from sleep, उसको arousal threshold कहते हैं. लूप गेन मतलब ये हुआ कि अगर पेशेंट ने जैसे एक बार उसकी ब्रेथ टूट गई तो उसको कॉम्पनसेट मतलब सेंट्रल स्लीप एपनिया में काफ़ी ज़्यादा वो आता है कि पेशेंट को काइंड स्ट्रोक्स रेस्पिरेशन होता है कि मतलब उसको इस तरह से वैक्सिंग वेनिंग पैटर्न में आता है. तो एक ऐसा लेवल आता है जब उसका जो CO2 लेवल होता है वो उसके एपनिक थ्रेशोल्ड से काफ़ी नीचे चला जाता है. तो उस एपनिक थ्रेशोल्ड को मतलब और उसके कॉम्पनसेशन में पेशेंट फिर से काफ़ी तेज ब्रेथ लेता है, तो ये साइकिल रिपीट होती रहती है. तो उस साइकिल को कम करने के लिए मतलब कि जो आपकी इनिशियल प्रॉब्लम है उसका रिस्पॉन्स ज़्यादा ना हो, उसको कंट्रोल करने के लिए हम जो देते हैं उसको कहते हैं हाई लूप गेन. तो लूप गेन कम करने के लिए जो हम देते हैं पेशेंट को कार्बोनिक एनहाइड्रेज इनहिबिटर्स देते हैं या ऑक्सीजन थेरेपी देते हैं. इसको डे टू डे प्रैक्टिस में इसको लाना थोड़ा कठिन है, ये थोड़ा एडवांस पैथोफिजियोलॉजिकल मैकेनिज्म्स हैं जो विद एक्सपीरियंस थोड़ा सा स्लीप स्टडी रिपोर्ट देख के आपको समझ में आता है.
How long the patient has to use PAP therapy?
At least 6 to 8 hours at night. मतलब 4 to 6 hours at night minimum. And for how long? अब इसके लिए डिपेंड जैसे वही है कि अगर आप मॉडरेट OSA में है, आपने उतना वेट लॉस कर लिया कि आप माइल्ड OSA आपने अपना HI नॉर्मल ला दिया, तो मे भी हम कहेंगे कि आप अब अवॉइड कर सकते हैं. लेकिन अगर आपका HI 50, 60, 70 की रेंज में है, मे बी योर इवन सिग्निफिकेंट वेट लॉस, your surgery, your tonsillectomy, your adenoidectomy may not be sufficient in that case. In that case, you can, after your procedure, maybe after your surgery, you can get a sleep study done again to look what the current situation is. And after that, you can decide on PAP therapy. At times, it has to continue for long.
साउंड स्लीप नहीं आती, रात भर स्वप्न आते हैं डरावने, उसका क्या?
अब वो सर एक और
मैंने पूछा था हमारे बैच के PhD में है, बोले बीके सिंह परेशान हुई है, जो आप सोते हुए आता है फिर तो एक्टिव रहता नहीं है, तो इसका कोई रास्ता नहीं है.
ये सर पैरासोमनिया भी हो सकता है. ओल्ड एज में अगर आपको कोई न्यूरोलॉजिकल प्रॉब्लम्स हैं,
कोई प्रॉब्लम नहीं है, जिस दिन मूड ठीक रहता है उस दिन ठीक आता है स्वप्न.
मेडिटेशन करके सोइए सर, मेडिटेशन करवा के सुलाना पड़ेगा आधा घंटे 15 मिनट.
नींद आती है, साउंड स्लीप
उसके लिए
मेहनत हो जाता करते हैं.
For any surgical intervention, इसके लिए long term में कितना effective है? There are studies saying that there are जैसे UPPP है, अगर आप वो कर रहे हैं तो it is effective immediately, but it in like 5 or 10 years it resets.
See, that is what I'm saying. The surgery can never be the mainstay of treatment in this sleep apnea. It is always a second line or maybe a third line treatment for the management of sleep apnea. Per se, I've never got any of my patients having done a UPP and come back to me. So personal experience with these surgical techniques is less, but these things are described. But what I have read in literature, per se, these techniques are not completely effective. Even if you get a UPP done, after that also your AHI will not come down to normal or in the range of mild OSA. That is all.
What type of surgery you recommend?
The most important surgery is a tonsillectomy or adenoidectomy in children. If that is the problem, if you treat that, that is maybe in many cases 100% treatment. Because you cannot ask a 5-year, 6-year, maybe a 10-year child to apply PAP therapy. You'll throw it away in one day. So there the first line of treatment becomes surgery, adenotonsillectomy. In adults, there was one movie of Abhishek Bachchan, I cannot recall the name, in which he started developing in which he went, maybe he had multiple surgeries. In that he got a mandibular advancement mandibular advancement technique done, in which his whole jaw had to be protruded outside. So that is a surgery which can be done. But say in practice, there are less surgeons who are doing all these surgeries. So I haven't got any of my patient done this uvuloparatoplasty or hypopharyngeal nerve stimulation. These are just experimental techniques, not in practice at present, at least the places where I am working.
You had shown one of the slide regarding the oral cavity palatal artery. Can you show me again?
Yeah.
First slide.
First slide or second slide, something. Now what is your comment on it? No, not this.
Malampatti.
Malampatti.
3 finger, 2 fingers.
So this is commonly used by anesthesia people before they're in their PSC checkup. So what we see, Malampatti, we can see up till the posterior lateral tonsillar pillar, and we can also see the posterior pharyngeal also. This patient has a broad open airway. So if he has an open airway, there are less chances of collapse. Then as your Malampatti increases, you cannot see the posterior pharyngeal wall. You can see the uvula, you can see the soft palate, and as you come further, even your uvula becomes half seen and only soft palate is seen. And in Malampatti 4, only your hard palate is seen. So if you are asking the patient to open your mouth, you can hardly see anything. So these patients are at significant risk of OSA. This can be a screening tool, general screening tool, which we can just put a torch in his mouth and see whether we need to go ahead or not.
Finger से measure करते हैं.
Finger and 2 finger people. Anesthesia people commonly use this 2 to 3 finger.
How many patients, you have last year, 1 year of practice in Gorakhpur, how many patients you have started on this treatment? You have diagnosed and started these treatments?
Nearly 25 patients.
25 patients.
On
You are doing in city hospital?
Last one, in city hospital. In that, nearly 10 walking-in patients who have come to me in OPD. And since it is a multi-speciality setup, we are diagnosing a lot in this patients of what I told, resistant hypertension, stroke, encephalopathy. Matlab they are having these problems and they are getting admitted. They are having 3 admissions in last 2 years, 3 years. So once I have titrated them on PAP therapy, given them the device, there has been no admission in last 1 year. So this is a very big take that if you're in a general medicine specialty, if your patient is getting admitted for some complaints such as stroke, recurrent stroke, or recurrent AF, or resistant hypertension, or heart failure, if he is getting again and again, try to dig in deep. Just don't, at times we give CPAP therapy, we give steroids, patient goes home. But at times PAP therapy may be needed at home to prevent him coming from the hospital.
Your 25 patients are on PAP therapy more or less?
Nearly, at least 20-25.
And they are satisfied, there are no complications as
A big chunk of them are satisfied. A few patients have such as that what I said. One of the heart failure patients I initiated in on PAP therapy. So within 3 days he threw up the therapy, he came to me that I'm not feeling better with this device. So I had to get into deep, I had to give him an ASV device, that is adaptive servo ventilation. This is a further enhancement in your PAP therapy, which we, as we go further into practice, we try giving BiPAP therapy or ASV therapy, depending upon the response of the patient.
ASV is a different machine.
ASV is an adaptive, this is a different algorithm within the PAP machine. This machine is a bit more expensive than the usual PAP machine.
Any more?
What do you recommend for those patients who are having morbid obesity? So many times they cannot tolerate CPAP. When you
So that is what in that morbid obesity you have to look for.
They won't tolerate it, and for many nights they don't tolerate it.
So what in morbid obesity you always get an ABG done. They might be suffering from an obesity hypoventilation syndrome. So in obesity hypoventilation syndrome, what happens is your CO2 levels also goes up. In that, your CPAP therapy will not be effective in many cases. You have to switch to BiPAP therapy or ASV therapy. Apart from weight loss, management of the underlying condition, heart condition or whatever is happening.
All the patients with snoring should go for polysomnography or only severe?
No. Snoring per se is one of the symptoms. That is what I am saying. Just we have to look at the other parameters. If he is complaining of excessive daytime sleepiness, he is overweight, he is on hypertensive therapy, just mild snoring, that can come when you are excessively tired. You might lie down and sleep, you might snore for some day. That just mild snoring is not, that is what we are saying. general screening in general population is not recommended by polysomnography. If you have pre-test probability is high, then go ahead with polysomnography or multiple comorbidities.
Let's say that there is a patient who is like having an AHI of 70 and he has a BMI of 29. Then obesity has no like what can they do without surgical intervention or like a CPAP therapy? Even if they have a CPAP therapy, if it is not getting tolerated, what is the down the line what they can do?
That is what in these cases we have to do a in-lab polysomnographic test. In that we have to keep the patient in the hospital for 1 day, we have to do the EEG, EMG, EOG studies, and a detailed workup is needed so that we can encounter what is the problem. If his problem, in that these mechanisms come through, that is the loop gain, arousal threshold, muscle responsiveness. We have to try to dig in deep and try to find out what is the problem which is not making him tolerate a CPAP therapy. Because an AHI of 70, if he is not using, his quality of life will be hampered for sure.
मल्टीडिसिप्लिनरी टीम अप्रोच टाइप का भी हो जाता है बीच में, जैसे उन्होंने बोला कार्डियक इश्यूज हैं या कुछ भी हैं तो कार्डियोलॉजिस्ट का इन्वॉल्वमेंट भी रहेगा आपके, तो कई तरह से टीम वर्क एक तरह से हो जाएगा, बट मेन फोकस जो पेशेंट कंप्लेन करते हुए आया है वो रेस्पिरेटरी की वजह से आप डील कर सकते हैं।
कंप्लेंट्स तो इसमें बहुत ही वेग से रहते हैं
क्योंकि इससे पूरी मल्टीडिसिप्लिनरी हो जाएगी इसमें। Any other questions or you should start?
Cost of polysomnography.
Cost of
polysomnography in a sleep lab.
Sir, we are doing it at 2,500 rupees. At home, if they are going at type 3 study, yes, ma'am. At home, if they are going and doing, they do it for 5,000. And if we are doing a level 1 or level 1, actually we don't have that setup is very expensive, so we are not doing that. Level 2 study we are doing, that is approximately 8,000.
Level 2 is 8,000.
8,000. Level 3 we do it for 2,500, and with titration we do it with 5,000.
I would like to invite Dr. Naresh Agrawal, sir, our Vice President, to give the certificate towards Dr. Vatsal.